Hello, I'm Dr. Elijah Salzer. I'm a physician assistant who practices obstetrics and gynecology. I am a clinical professor at the Pace University Department of Physician Assistant Studies. I continue to work as a physician assistant in private practice in the Bronx in gynecology, as well as I serve as a sexual assault forensic examiner at the Mount Sinai Hospital in New York. I've been practicing obstetrics and gynecology for um, about 34 years now, and it's all I've ever done as a PA. It's my pleasure to speak to you today on the topic of what's new in vaginitis today at the Charter Oak Conference of the Connecticut Academy of Physician Assistants. There are a couple of disclosures I'd like to make. The first is that I do serve as an expert witness. I serve as president-elect and co-chair of the Education Committee for the LBGT caucus. I'm also co-chair of the PAEA Sexual and Gender Minorities Special Interest Group. I don't have any other conflicts of interest to disclose, and I also certify that this material is based on current standards of care. Our objectives include that you will, at the end of this presentation, be able to discuss the pathophysiology, history, physical exam findings, relevant laboratory studies, and management of the most common types of vaginitis. And the entities we're going to consider today are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. We're going to discuss systemic barriers to the care of patients with vaginitis and discuss management of recurrent and/or complicated vaginitis. We have a case today of a 21-year-old nulla gravida. LMP was a week ago complaining of a foul-smelling, watery, slightly pruritic vaginal discharge for 3 weeks. She denies douching, and she also states that she does not use condoms with her male partner, with whom she's been having sex for about a month. It is normal for patients to have vaginal discharge when they're of reproductive age, and even beyond in some cases. But before menarche begins, it is uncommon. Um, it may well represent another process, such as a foreign body or perhaps sexual abuse. But typically, normal vaginal discharge is white, yellow, or clear, and it changes throughout the menstrual cycle. For example, it's very common that patients may note a thick, very clear discharge, almost with the consistency of rubber cement, right around the time of ovulation. And that is there to uh, make it easier for sperm to be transported up to the fallopian tubes around the time of ovulation. Patients may also notice more discharge of that type when they're using some kind of hormonal contraception, and that's usually due to the progesterone. It can also be associated at times with even a levonorgestrel containing intrauterine device, but more commonly seen with oral contraceptives, the contraceptive vaginal ring, the subdermal contraceptive implant or Nexplanon, or a contraceptive patch. It should be non-pruritic, it should be non-malodorous, and it shouldn't be associated with any kind of pain, whether that be abdominal pelvic pain, dysuria, or anything like that, when the discharge is normal and therefore physiologic. At the time that estrogen is produced, and people make 11 different kinds of estrogens, um, the there is the production of lactobacilli, and they are present in the vagina because of estrogen. And through their production of peroxides, they maintain the vaginal pH no higher than 4.5. And that turns out to be an important adaptation. Um, because if it gets above 4.5, you often have trouble. And the reason for that will be discussed when we get to bacterial vaginosis. The most common vaginitides are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. And if you add them all up, the lower numbers get you to about 65%, but the higher numbers get you to 125%. And the reason for that is that these can coexist. A patient could have yeast and also have trichomoniasis and also have chlamydia, which is not a vaginal infection, but it is entirely possible. The only one that is truly considered to be an STI as we understand them today is trichomoniasis. It is not rare at all, as I'm sure you know, for a patient to contact you directly or through your office or portal asking to receive a prescription for a medication for a vaginitis because they know they've got it again and they really need the medication. Perhaps they're going out of town, they don't have time to see you. Could you please just send it? And although it may seem unwelcoming to your patient, it actually is harmful to say, sure, I'll send you a prescription for fluconazole because, as you will see, the symptoms can really overlap. And I don't know how you could possibly tell exactly what the patient has. And this is not just my opinion, this is also the opinion of the American College of Obstetricians and Gynecologists. The other issue, of course, as we've already noted, is that patients can have more than one infection at a time. And it really is poor medical practice to make these diagnoses without seeing the patient in person. The other point is that if the patient has cervical cytology results that indicate infection, and that could be seeing fungal organisms suggesting candidiasis, or seeing a shift in vaginal flora, which would suggest bacterial vaginosis, or seeing trichomoniasis, trichomonads on the pap. It should not be relied upon as evidence of infection. You should bring the patient back, or if there is any suspicion, perform the appropriate tests at that time when you first saw the patient. We'll start by talking about bacterial vaginosis, which is seen in almost a third of patients around the world. And something happens. What that thing is not entirely well understood, but there's some kind of event that happens and it disrupts the vaginal microbial, microbial flora. And there really is, we talk about gynecology, and that was a famous book written by Mary Daly, who was actually a professor of theology at Boston College in the 1970s and beyond. And but of course, we are talking as well about the ecology of the lower female genital tract. And when it is thrown out of balance, you can have real problems result. In that, bacterial vaginosis is a very good example. In any case, we're not sure what that event may be. We have some theories, but the lactobacilli start to die off. And as a result, you have overgrowth of both facultative and strict anaerobes. There are many, many, many organisms that have been identified that are implicated with bacterial vaginosis, but nobody knows exactly which one for sure causes it. It is posited that exposure to semen may cause BV. We know that semen is much more alkaline than the vagina is. It could be the use of tampons, and tampons have a lot of ingredients in them, if you will. And when you see a patient who's getting repeated vaginal infections, you may want to suggest to the patient that they change to cotton tampons or pads. And you can buy these things online or in a health food store. Or douching. And douching is something we addressed about 25 to 30 years ago in gynecology and suggested to patients that it could be harmful. Why? There are two factors. Number one, you may well be washing away lactobacilli from the mechanical force. Number two, you may be forcing other organisms, for example, gonorrhea, up into the upper reproductive tract, and that could be a mechanism by which people get pelvic inflammatory disease. We have observed that condoms seem to reduce the incidence of bacterial vaginosis, and that male partners who are uncircumcised, who have female partners who have recurrent bacterial vaginosis, who get the male partner becomes circumcised, that can reduce the incidence of BV by about 50%. And we know that Gardnerella can form a biofilm in the vagina that actually reduces lactobacilli, and that can help bacterial vaginosis continue. Now, one question that a lot of people have asked is BV a sexually transmitted disease? And that's something that many, many, many of us in OBGYN have wondered about for years. And I can't absolutely answer that, but what I can tell you is that there was an article published almost exactly a year ago, it's March of 2025, in the New England Journal of Medicine, that was a small study. It only included 164 couples, and it was a small open label randomized controlled study. The women had all tested positive for bacterial vaginosis, and they had gotten first-line therapy. And that, by the way, to give it away, first-line therapy is metronidazole. There were two groups of men. There was the partner treatment group, and those men received metronidazole 400 milligrams orally twice daily for a week, and as well as 2% clindamycin cream that was applied topically to the penis twice a day for a week. In the control group, the men didn't receive any treatment. And the study was actually halted because of the results that revealed that there is a really significantly decreased risk of recurrence of BV among the women in the partner treatment group. The recurrence rate was 35% compared to the control group that was 63%. And we'll talk more about that before we're done with our discussion of BV. In terms of the history, you want to ask about how long the patient has had symptoms. Has this happened before? Because recurrence is so very commonly seen with bacterial vaginosis. The sexual history, and it is commonly seen with when a patient, such as our case, has started being sexually active with a new partner, as well as in patients who have anal sex immediately followed by vaginal sex without washing the penis or the sex device, or without changing the condom or using a condom. There is also today a plethora of feminine hygiene products, and there are all sorts of things on the market. You can peruse the aisle at Walgreens or CVS or wherever you go to the drugstore and look at all the things that are there, or go on Amazon or another online store. And not all of these things will help. In fact, many of them will not help. And these are very often tried by patients because patients get rather desperate about vaginal infections, especially when they're recurring, and they'll turn to other sources, and they may not help them at all. But we'll talk more about that. It's also a good idea to ask the patient if there is any association between their symptoms, the onset of symptoms, and menses. It is not at all rare that a patient will report as soon as their period is over, that's when they start having bacterial vaginosis or symptoms of it. On physical exam, classically, you'll see a thin, homogeneous, gray to white discharge that may have a fishy odor. And by the way, not everybody can appreciate that. I am one of the people who physiologically is not able to notice it, so I have to rely on my patients. And some of you may have the same issue. There may be pruritus, and this underscores the point I made before about how patient may say, I just need a prescription for diflucan because I know I have yeast. You don't know without actually evaluating the patient in person. And dysuria can also occur with bacterial vaginosis. But the patient usually doesn't have symptoms of systemic illness. They're not febrile. They usually are not in pain. You can also rely on Amsel's criteria. You need a microscope to do it, but you can see the discharges we discussed, thin, homogeneous, gray to white. The presence of what we call clue cells, these are epithelial cells whose borders are obscured by anaerobes. And I'll show you what it looks like shortly. You can add potassium hydroxide to a sample of the discharge, and that will liberate the amines that will give off the fishy odor. And you can test the pH. It should be more than 4.5. You can also send the test out to the lab, which is what I always do. And you can do that by DNA hybridization or detection of vaginal fluid cyatolase. You can also use point of care testing, and this is very, very accurate. However, it is expensive, and you also need the staff, their time and their effort to perform these tests. It might be you doing it. And these are what some of the tests are evaluating for. And this is the discharge you would see, and you can see it, in the posterior vaginal fornix and on the cervix. However, could I tell that this is bacterial vaginosis simply by looking at it? No, I can't. It might very much be BV, but it could also be normal, especially right before menses. This demonstrates for you that a pH of greater than 4.4 does suggest bacterial vaginosis. This is a normal wet mat, and you can see we have rods. The rods are lactobacilli, and you see one white blood cell, maybe two, and you see epithelial cells. We see a number of them, maybe about 5, and they all look fine. You get actually more like 6 or 7. You can see their borders very easily. They are not covered with bacteria, and everything looks normal here. I often think of this as being like when you dive into the ocean and you're scuba diving or snorkeling, and you see a nice, healthy marine environment. The coral are healthy and flourishing, and you see lots of fish, and maybe you see an octopod and things like that. And if you've snorkeled or if you've dived in places where there are very few healthy coral, it's really stark. And this looks like a very healthy reef to me. And then you go into not a healthy area, and you can see right immediately the lactobacilli are gone. There aren't any. And you can see the epithelial cells are completely covered with bacteria that are adhering to their surfaces. This is what a clue cell looks like. You need 4 of them per high power field to make the diagnosis. In terms of first-line therapy for bacterial vaginosis, that's metronidazole. You could use oral metronidazole or vaginal metronidazole. However, especially for the first infection, oral metronidazole is very much preferred. It's 500 milligrams twice daily for a week. And the warning about using oral metronidazole in patients who drink alcohol because of the disulfiram-like effect has been removed, because there was lack of evidence that that actually was an issue. You can use topical vaginal metronidazole, as I said. That's a 1 applicator full intravaginally at bedtime for 5 days. Technically, you could use it at any time of the day because it's a gel and not a cream, and so it should adhere, but I think it's probably better at night. Excuse me. You can also use vaginal clindamycin, and that is a 2% cream used at bedtime, 1 applicator at bedtime for a week. There are alternative regimens. They are all very, very similar to metronidazole, and that's secnidazole, which is still branded and therefore expensive. It is a single dose. It's a sprinkle on food. Tinidazole, which is still branded, I believe, still expensive. Most insurance plans will want demonstration that the patient had a treatment failure with metronidazole or clindamycin. And that is convenient in that it's given only once a day, either 2 days in a row for with 2 grams or 1 gram for 5 days. And you can use oral clindamycin as well, which I have found to be very effective as well. Or you could use a different form. This is now not the cream, but the ovules, and that goes on for 3 days. BV can have sequelae. In pregnancy, it can cause pre-labor rupture of membranes, which means that the patient is not in labor, but does rupture membranes. It can also be associated with preterm pre-labor rupture of membranes, which is the same entity, but now the patient is less than 37 weeks pregnant. And of course, premature pre-labor rupture of membranes could be associated with the consequences of prematurity for the fetus. In patients having gynecologic surgery, a lot of times we do enter the vagina during gynecologic surgery with vaginal surgery, uh, cervical surgery, cervical cerclage, conization of the cervix. Um, you could also enter the vagina with a total abdominal or laparoscopic hysterectomy. And those cases, when a patient has bacterial vaginosis, can lead to an increased risk of cellulitis of the vaginal cuff or the vagina. Because a lot of patients are asymptomatic with bacterial vaginosis, you could either screen for BV before the patient has surgery, or you could simply give them metronidazole IV during the surgery. Either one is appropriate. It is also associated with an increased risk of transmitting HIV to the male partner, as well as co-infection with genital herpes, gonorrhea, or chlamydia. In terms of the management of recurrent BV, which, as I mentioned earlier, is very common. If you see a patient today for BV, almost a third of them will have it again within a month, and more than 50% will have it again within a year. In terms of access to care, it is difficult for patients to be able to take off time to see you and to get medication. And there are, as we know, health disparities that make it difficult for patients to get care. There are issues of patients trusting a medical system that they perceive has failed them because they get these infections over and over and over again. And for patients who especially are marginalized in terms of income for whatever reason, disability, race, being undocumented, whatever it may be, they may very well be more likely to be in a public facing job. And they may be very, very, very concerned that the odor they perceive is perceived by others. And that can cause real effects on how they feel mentally, how they feel about their bodies, about the disturbances they have with the odor, the itching, the dysuria, as well as sexually. And it's my belief that many, many, many patients coming for gynecologic care experience significant shame about their bodies. And we're not just talking about bacterial vaginosis. That can happen with patients with abnormal bleeding, with concerns about the appearance of their genitalia after delivery, with concern about other entities that cause them vulvar pain, like vulvodynia or vestibular disorders, or warts, genital warts, all sorts of things like that. And that makes these things very difficult too in terms of their sexual relationships and well-being. What you can do for recurrent bacterial vaginosis are several things. Number one, you can use the gel, the metronidazole vaginal gel, uh, intravaginally at bedtime once daily for 10 days, and then you go to twice a week for 6 months. The other regimen is boric acid vaginal suppositories, 600 milligrams at bedtime for 3 weeks, and at the same time prescribe a standard regimen, and that could be either the oral metronidazole or perhaps oral clindamycin, because you would not want to use an intravaginal preparation along with the intravaginal bacterial vaginosis. Boric acid suppositories, by the way, can be ordered through a compounding pharmacy, which often will not be covered by insurance. and can be quite expensive. The other thing you can do is these products are available online. In either case, you can never know for sure what's in them, and that can be of concern. I had a patient a number of years ago who went to the ER and was told by a physician there that she should go to the supermarket and buy a box of roach powder and pour it into her bathtub and sit in it. And that would take care of her bacterial vaginosis, which of course is a very, very bad idea. The other alternative regimen is metronidazole, a single dose, 2 grams, and fluconazole, 150 milligrams. And the patient takes that monthly after, again, they complete a standard regimen. Now, if you're wondering why we're talking about fluconazole, it seems to me, with knowing about these things, that there is some association between BV and yeast. Uh, and I certainly don't understand it. I don't think anybody fully understands it, but there is an association. In patients who have sex in a same-sex relationship, both patients were assigned female at birth. If the partner is symptomatic, then that person should be treated. And in people who are assigned female at birth, who have sex with people assigned male at birth, again, as I mentioned, the male partner should be using metronidazole, 400 milligrams twice a day by mouth, along with clindamycin 2% cream applied topically to the penis twice daily for a week. And consider condom use and consider circumcision. There is one study that found that a live biotherapeutic product containing Lactobacillus crispatus that is used for 11 weeks after treatment with metronidazole was beneficial, but the Lactobacillus crispatus did decline 12 weeks later. Uh, People ask all the time about using probiotics for bacterial vaginosis and other forms of the vaginitides, and there's no evidence to suggest that it's effective. There is a study ongoing about transplantation of the vaginal microbiome that does seem to be beneficial, but it is premature to say for sure. All right, let's continue our discussion. Moving on now to vulvovaginal candidiasis. And about 70% of patients are going to have yeast at least once in their lives. This is due to an overgrowth of candida. And that classically is due to a patient who, let's say, um, needs antibiotics before they have root canal. They're on vacation and they get a terrible toothache and they see a local dentist who gives them some amoxicillin and they need to go get a root canal when they're home. But while they're on the antibiotic and unfortunately also on their vacation, they have this terrible vulvovaginal pruritus and this curd-like discharge because they've got yeast. The other thing that's well known for causing candidiasis is change in uh, levels of estrogen and progesterone, either from pregnancy or from uh, contraceptive devices, such as vaginal contraceptive rings, uh, the the oral contraceptives, Depo-Provera, the contraceptive patches, things like that. Patients who have been undiagnosed, they have undiagnosed diabetes and or HIV, or they need steroids, or they are immunosuppressed because of a transplant. Those patients are all increased risk of having yeast. Most of the time, the kind of yeast that is affecting the vagina is Candida albicans, about 70% of cases. However, there was a time when it was about 90% of cases that were caused by Candida albicans. And the second most common is Candida glabrata, and we're going to talk about that separately. The patient with yeast typically has a very, very intense pruritus of the vulva and vagina with a white curd-like discharge. The patient may also have dysuria. And the reason for that is because they've scratched themselves and now they're urinating on tissue that is excoriated. And they may also have dyspareunia. On physical exam, you'll see the white curd-like discharge. You may see hyperemia of the vulvar tissues and excoriations. And this is exactly what yeast can look like. Again, you can certainly look at a patient like this and say, yeah, that's a yeast infection, but you probably won't know what kind of yeast is causing it. So my personal opinion is that these patients should be tested for the form of yeast. You could treat them empirically for Candida albicans, and if they get better, then that can be okay. But my practice is that I usually will test for the type. Here you see the excoriations and the hyperemia, particularly in the image all the way to the left and the one all the way to the right. I will remind you that your diagnosis should be made on patients who are standing in front of you. You can look under the microscope if you're fortunate enough to have one, and look for pseudohyphae or hyphae or spores like you're back in fourth grade science class. You can perform a culture or commercial testing. I will remind you not to rely on your cervical cytology results because they are considered to be unreliable, or to treat a patient presumptively without having examined them. Here you see pseudohyphae. These are seen in the presence of Candida albicans on a wet mount. And your PCR testing is very, very sensitive and specific for these forms of yeast, and these are almost all of the ones that are associated with vaginal candidiasis. In terms of uncomplicated versus complicated yeast, uncomplicated yeast occurs episodically. The patient has some mild symptoms, maybe moderate symptoms. It's usually Candida albicans, and their immune system is intact. Patients who have complicated yeast have 4 or more episodes a year with severe symptoms. They often have an infection with a non-albicans form, and their immune system may be compromised. I had a patient earlier this week. Actually, I saw her a week ago today, but I had results for her on Saturday. And she had bacterial vaginosis, albicans, and Candida glabrata. So she got treated with metronidazole for the bacterial vaginosis and 2 medications for yeast, but I won't tell you what they are yet because we're not there yet. Over-the-counter medications certainly can work. You can use clotrimazole or tiaconazole. You can use miconazole creams or suppositories. Either of those is fine. But the problem is that even though the medications work well, the patient may not be a good diagnostician. They may assume that if there's something going on down there, it's yeast. They may not know that bacterial vaginosis can cause similar symptoms. A lot of people assume BV only has an odor, it doesn't itch, and it doesn't make you feel like you've got a UTI. But in fact, it can. The other possibility is that your patient misunderstands what treatment is for yeast that would, treat it and not just mask the symptoms. The patient could buy a topical anesthetic for the vulvar area and will feel better, but you haven't solved the problem. Or the patient could buy something like a homeopathic product that may not treat the patient adequately. So only about a third of your patients will diagnose themselves correctly with yeast. And the other thing is you may have a patient who has more than one infection because these things can absolutely coexist. You can have bacterial vaginosis and, chlamydia and candidiasis all at one time. If your patient does come to you and you decide to treat with a prescription medication, for most people today, they're using fluconazole. It's a single dose. It's oral. It's very easy. There's no mess. However, you could use any of the other vaginal creams, butaconazole or trichomoniasis, which comes as a 7-day cream, a 3-day cream, or 3-day suppositories. And the cream and the suppositories are equally effective. What about patients who have recurrent Candida albicans infections? The risk factors, again, immunosuppression, poorly controlled diabetes or diabetes that hasn't been diagnosed yet, use of antibiotics, of course, and there are patients who have to use antibiotics repeatedly, or recurrent bacterial vaginosis because there is this association between the two. In this case, the patient has at least 3 episodes within a year. You need to see documentation, and culture is the preferred means of diagnosis, although it is hard to obtain. And what you primarily will see is Candida glabrata. And what you want to use to treat glabrata is trichonazole. With a patient as recurrent Candida albicans, you can treat with fluconazole 150 milligrams. It could be 200 milligrams. And the patient takes 1 tablet every 72 hours, and they do that for 3 doses. And then they go on to fluconazole, 150 milligrams every week for 6 months. Half of your patients will relapse after that 6 months is up, but the other half won't. There is a new non-azole agent for the treatment of candidiasis, and this can be for primary vaginal candidiasis or recurrent candidiasis. And it's called ibrexafungerp. It was approved by the FDA 5 years ago, and it is an initial treatment. You take it every 12 hours, one day. And for recurrent vulvovaginal candidiasis, you take 300 milligrams every 12 hours for one day, but it's every month for 6 months. And this does have limitations in terms of the potential for real harm with pregnancy. In terms of other things you can do for non-Candida albicans vaginal infections, you can use boric acid for at least 14 days. That's 600 milligrams suppository. And there's flucytosine, which is really expensive, over $150 a day, and this goes on for 14 days. I serve a population which 85 to 90% of my patients are on Medicaid or Medicare or both. They can't possibly afford this, and Medicaid isn't going to pay for it. In terms of severe symptoms, you can have patients who have what we call intertrigo with really, a lot of edema, a lot of fissures. It kind of looks like the patient went hiking in, the Okefenokee swamp in Florida, wearing army boots with thick socks. And they went there for 5 days and never took their socks or shoes off, and then finally took off their socks and shoes. That's what the vulva looks like with intertrigo. And what you generally use for that is clotrimazole and betamethasone together twice daily in the vulva for 14 days. You can also use a long course of trichonazole, and you can use the prolonged course of fluconazole, as I suggested before. All right, that's it for our discussion about yeast. We're going to move on next to trichomoniasis. And this is a line in the sand because trichomoniasis is the only definite STI associated with vaginitis. There are about up to 5 million cases annually in the United States, and this is caused by Trichomonas vaginalis, which is a flagellated protozoan. You can get trichomoniasis from a fomite, primarily a sex device. Is it possible to get it from other things? Probably, but it's not very common. And one of the problems with trichomoniasis is that trichomonads can attach to the epithelial cells, and they have parasite-mediated apoptosis. And the cell lyses and the epithelium gets eroded, which means you have access to the blood supply. And we'll talk about that. The other issue is that we think that the trichomonads can hang around the vagina because they need iron, and you've got all this menstrual blood in patients of reproductive age. 80% of cases of trich are asymptomatic, although it is unusual in that more women assigned female at birth have symptoms than people assigned male at birth. It is also the most prevalent non-viral STI in the world, the most prevalent STI in the world is, of course, human papillomavirus, which of course is a virus. And risk factors for for trichomoniasis include a history of BV, lower socioeconomic status because of disparities in care, as well as implicit bias among clinicians, and a history of incarceration, which, certainly makes one think about sexual abuse in among carceral uh, circumstances. Uh, and it can persist during menopause. This can be something that hangs around. Uh, and this can be in patients who are widowed or divorced and don't know they have anything. And maybe the patient is 58 and has been divorced for some time and comes to you for routine gynecologic care, and you perform cervical neoplasia screening, and you come back with the result being trichomonads identified, and you say, yeah, but Dr. Salzer said don't trust the result for infection. Test the patient, and sure enough, they've got trichomoniasis. We think the reason that happens in older patients may well be the lack of estrogen. Anyway, patients like with bacterial vaginosis or yeast can have pruritus. They can have vaginal pain, which is less commonly seen with candidiasis, dysuria, dyspareunia, frothiness of the discharge, and I will show you what that looks like. Very often these patients have a worsened infection with menses, maybe because of the presence of the menstrual blood. Perhaps this helps the trichomonads proliferate because they need the iron. And it is associated with pelvic inflammatory disease, which could explain why these patients can have abdominopelvic pain as well. The PANTS will ask you, in many cases, about the classic presentation of trichomoniasis, and that they will tell you is a yellow to green discharge. And again, it's good to know what the classic presentation is, and sometimes it really is the classic presentation, sometimes it's not. And I personally have seen trichomoniasis be every color except for black, orange, purple, and blue. But then I've never seen vaginal infections be any of those colors in nature. But what it is frothing, whatever the color is. You can also see a strawberry cervix. I'll show you what that looks like in a minute. You can have urethritis or infections of the Skene's glands. And again, you can have pelvic inflammatory disease, which presents with abdominal pain along with abdominal tenderness, along with at least one of the following: cervical motion tenderness, uterine tenderness, and or adnexal tenderness. But you could have 2 or 3 of those. This is what the trichomonads look like under the microscope. And this is the frothy discharge. Now, you may also be able to appreciate that the cervix looks kind of angry. It looks sort of beefy red. But you can see how the discharge is frothy and it's not yellow or green. Here's a strawberry cervix, and this shows you the eroded epithelium, and that it doesn't really look much like a strawberry, but you can see the lesions. And this is why patients can be at increased risk of contracting HIV or communicating HIV to a patient when they've got trichomoniasis. In terms of diagnosis, you can make the diagnosis on microscopy with the identification of motile trichomonads. They must be motile. You cannot make this diagnosis if they are not motile. The sensitivity is as high as 82%, but it's as low as 38%. Nucleic acid amplification testing is very effective, with a sensitivity of up to 100%, specificity up to 100%. And you can also do this with samples from the cervix, the vagina, or from urine. And that's particularly good with a patient who cannot tolerate a pelvic exam, or you might have an adolescent whose parents suspect or have discovered that the patient is having sex and they're worried about pregnancy and they're worried about infection, and the patient is 14 years old. And if the patient feels well, there's really no reason to put that patient through a pelvic exam. You can have a urine sample, and test for gonorrhea, chlamydia, and trichomoniasis, and get blood for HIV and syphilis, and take care of things that way. And you do not need to perform a pelvic exam to provide contraception except for an intrauterine device, and that's a different lecture. You can use antigen detection testing. We talked about the limitations with that in terms of cost, both the financial cost of providing the tests, although you can bill for it, and also the time it takes the staff to perform that test. Sensitivity is not bad, up to about 88%. Specificity is superb. And then you could perform a culture, although it's technically pretty difficult because most labs don't have the ability to do it. And the results take, going on a week, and that's a long time to wait for results for an infection. Sequelae, as we've mentioned, include pelvic inflammatory disease, which certainly can lead to infertility, preterm birth, and HIV infection and transmission. And it is associated also with cervical intraepithelial neoplasia. There was one study that found that almost 10% of patients who had trichomoniasis, they'd been treated, and they had not had any sexual activity in the 3 months before, still tested positive. There is another study that found that over 40% of patients who had been treated for trich still had it. And we know, as I mentioned earlier, that patients who are over 35 might have persistent infection, maybe again because of waning estrogen levels. And interestingly, people are not the only animals on the planet that seem to have this issue with trichomonads. It also apparently occurs in birds, and I don't know what part of the bird this is an issue in, but there you go, of some interest perhaps. In terms of managing trichomoniasis, there are only two medications, two of the 5 nitro-imidazole agents, and that's metronidazole, 500 milligrams taken orally twice daily for a week, along with tinidazole, if the patient can't take metronidazole for some reason or perhaps has failed treatment. The partner also should be treated because this is a sexually transmitted infection. As a result, you also want to test for HIV, syphilis, gonorrhea, and chlamydia. It is, at least in New York State, not a reportable infection. I cannot speak, however, to Connecticut or other states. To conclude, if you go back to our original case, we diagnose our patient with bacterial vaginosis. We reassure her that at this time it's not classified as a sexually transmitted infection. You prescribe metronidazole, 500 milligrams taken twice daily for a week. She visits you 2 months later for an annual visit and tells you that the infection got much better very quickly. Here are my references. And if you have any questions, I'd be very pleased to hear from you. Please do not hesitate to email me at esalzer, esalzer @pace.edu, and I will be sure to answer your questions. I do hope you enjoy the rest of the Connecticut Academy of Physician Associates Charter Oak Conference. It's been my privilege to lecture you today. Have a good day. Thank you.